Good evening and welcome to another session of conceptual surgery. Today we are going to be diving into thyroidectomy for our PG exams. So here we are not trying to approach thyroidectomy from the perspective of an atlas view. We are trying to approach it as to how you would attempt this question in your exam. If a question on an operative procedure comes, how should that question be approached to write in a descriptive exam? What should the headings be and what all topics should you cover? So for thyroidectomy, we are doing this class today and we'll be covering the salient features that you should be referring to when you're writing a descriptive answer in the exam. So in general, any descriptive question in the topic of operative surgery is best answered in the following descriptions under the following descriptors, which include a brief introduction to the procedure that you're going to be describing, then what are the indications for the procedure, then the relevant surgical anatomy, the anesthesia and positioning for this procedure, then we move on to the operative steps, and we conclude by mentioning the complications. So we are going to be following the same pattern for thyroidectomy. And first, we are just briefly introducing in one sentence what thyroidectomy is. As you all know, it would refer to a removal of the thyroid gland. Then we are introducing the topic of the types of thyroidectomy that exists. So as you all know, the various types are hemithyroidectomy, subtotal thyroidectomy, near total, and total thyroidectomy. So that what is the difference between these three? It's a very simple line diagram that you can draw in your exam. You do not need fancy drawing skills. But this is a diagram that you can manage in an exam setting, and any diagrammatical representation helps you fetch more marks. So thyroid has two lobes and an isthmus. So when we have removed all of it, it is called a total thyroidectomy. When we remove only one of the lobes and the isthmus, it's called a hemithyroidectomy. In subtotal thyroidectomy, we leave approximately 8 grams of tissue in the tracheoesophageal grooves bilaterally, and in near total we leave only 1 gram of tissue on one side only. That's a near total thyroidectomy. Now we move on to the next topic. So now we have briefly introduced the broad heading of thyroidectomy and we have discussed its types. Now we move on to the indications. So the main indications include malignancy and suspicion of cancer. It could be a confirmed thyroid cancer or a patient who has an indeterminate nodule, where after having performed the thyroidectomy, we will be able to establish a definitive diagnosis based on the biopsy report. Then we have another indication is for patients who have compressive goiters. The compression could be to the trachea or the esophagus, leading to difficulty breathing, a change in voice or hoarseness, or difficulty in swallowing. Then there could be a retrosternal extension which compresses upper mediastinal structures, leading to possibly a thoracic outlet syndrome. Then the further indication could be a cosmetic deformity, a thyroid which is enlarged enough to cause cosmetic distress to the patient, even if it's not causing compressive symptoms or there is no suspicion of malignancy in the nodule. Then we also perform thyroidectomy for overactive thyroid, hyperthyroid patients in Graves' disease, when medications cannot be tolerated or when medications cannot control the symptoms of hyperthyroidism after stabilizing and preparing the patient for surgery. Same for toxic multinodular goiter, which do not respond to medical therapy, and in cases of a toxic adenoma, which is localized, and we can remove it and cure the hyperthyroidism. For all of these patients, hyperthyroid patients who undergo surgery, a proper preoperative preparation is necessary. Now, we have already seen that there are types of thyroidectomies. So here we are going to be discussing the indications for a total thyroidectomy versus a hemithyroidectomy. So in advanced or bilateral cancer, when we have a confirmed cancer and the tumor size is greater than 4 centimeters, the nodules are present in both lobes, or we have evidence of lymph nodal metastasis or extrathyroidal extension. Then if the histology is aggressive, there is bilateral benign disease, which may be a multinodular goiter with compressive symptoms, or it's a Graves' disease when thyroidectomy is indicated. We already saw what were the indications for which we need to perform a thyroidectomy. So in Graves' disease, we would always be performing a total thyroidectomy and not a subtotal or a hemithyroidectomy. Then MEN2 syndromes. In these patients who have RET oncogene mutations, they should undergo total thyroidectomy by the age of 5 years in MEN2A and by the age of 1 year in MEN2B syndromes. So now indications for hemithyroidectomy. When we have a low risk thyroid cancer, which could be a well differentiated thyroid cancer of ranging of a size between 1 to 4 centimeter with no signs of spread beyond the thyroid capsule or to the lymph nodes. Then we have some indeterminate nodules, which could be Bethesda category 3 or 4, which are your follicular neoplasm and suspicious of malignancy, where molecular testing was unavailable or it was unconclusive. So we remove half the gland, and the biopsy of that gland serves to further direct the line of management that we take for the patient. After the indeterminate nodule has been excised, the patient has undergone hemithyroidectomy. If the biopsy report comes out to be an adenoma, the patient does not require any further surgery. However, if the biopsy report comes out to be a malignancy, the patient would then further undergo a completion total thyroidectomy. The other indication of a hemithyroidectomy is a unilateral benign mass, which could be a large nodule, cyst, or a toxic adenoma that is strictly confined to one lobe. Now, we have covered the brief introduction and the indications. Now we are going to be discussing the relevant surgical anatomy, but it's a brief description here. So, thyroid gland consists of two lateral lobes connected by a isthmus, and the isthmus lies over the second to fourth tracheal rings. In 50% of the patients, another pyramidal lobe is present, which arises from the isthmus and reaches up. We go on to discuss the vascular supply of the thyroid. So, first we'll discuss the arterial supply. So, thyroid is supplied through the superior thyroid artery and the inferior thyroid artery. In 10 to 15% of the patients, there will be an extra artery which is called the thyroidea ema, which may arise directly from the aorta. Now, the superior thyroid artery, it is the first branch of the external carotid artery, and the inferior thyroid artery arises from the thyrocervical trunk. Now, the venous drainage, we have three veins. So, two arteries and three veins. The superior and the middle thyroid vein drain into the internal jugular vein, whereas the inferior thyroid vein drains to the brachiocephalic vein. Now, the relationship between these arteries and the nerves around the thyroid gland is essential, because these are the nerves that we are going to be preserving when performing a thyroidectomy. So, the inferior thyroid artery has a very close relationship with the recurrent laryngeal nerve. The artery and the nerve usually cross each other at a 90-degree angle. So the nerve can be in front, behind, or it may weave through the artery and ascend up in the tracheoesophageal groove, then to enter the larynx. The external branch of the superior laryngeal nerve, this runs in close relationship to the superior thyroid artery, and when in a thyroidectomy, we will be ligating the superior thyroid artery. We have to be careful about preserving the external branch of the superior laryngeal nerve. This is the nerve which controls the pitch of the voice, whereas the recurrent laryngeal nerve is the one which supplies to the intrinsic muscles of the vocal cords, except the cricothyroid. Now, nerves in relationship with the thyroid, which are relevant to thyroidectomy, these include the superior laryngeal nerve and the recurrent laryngeal nerve. So, the more important of the two, the recurrent laryngeal nerve, it arises from the vagus. So, here in this diagram, you can see that the recurrent laryngeal nerve and the superior laryngeal nerve, they both arise through the vagus. We are first discussing the recurrent laryngeal nerves. The recurrent laryngeal nerves, after arising from the vagus, they proceed downwards and then they loop around to come back and supply the larynx. So on the left side, the recurrent laryngeal nerve loops around the arch of aorta, whereas on the right side, it loops around the right subclavian artery. So then it ascends up and passes in the tracheoesophageal groove. There is a non-recurrent variant where the recurrent laryngeal nerve directly proceeds to supply the larynx and it does not loop around the vascular structures. That is a very rare phenomena, and when this happens, it is more common on the right side. Okay, now the external branch of the superior laryngeal nerve. It runs closely alongside the superior thyroid artery and then goes on to supply the cricothyroid muscle. So to avoid damaging it, we take care that the superior thyroid vessels be ligated as close as possible to the thyroid capsule rather than an in mass dissection.